Thank you very much. I'm giving this lecture in English, and that's because several years ago I tried to give a lecture in Spanish, and I brought my daughter with me, who at that time was 13 years old, to Latin America so she could hear my speech. And her Spanish is very good. And after she heard me talk, she said, "Daddy, please don't ever embarrass the family again by talking in Spanish." So ever since then, I was completely traumatized, and I never want to give a lecture in Spanish again. But her Spanish is quite good. Here's the message that I want to give you today. And this morning you heard from Adrian Hill at the Jenner Institute at Oxford, who's really trying to advance vaccines in the nonprofit sector. And the Sabin Vaccine Institute is a fellow traveler like the Jenner Institute, although it's a smaller version. It's not as extensive as Jenner, but we do similar kinds of things in terms of making vaccines for the diseases that are not sufficiently profitable, that GlaxoSmithKline and the other big multinational companies cannot really go to their shareholders and get permission to make those vaccines. But we think they provide an important need in any case, because these are vaccines that have to be made for the world's poorest people. And I've been making multiple trips to Panama over the last few years with a very specific purpose, and that is, I think there's a potential to build a facility or an institute similar to Sabin through a Panamanian institution, perhaps through INDICASAT or others. In other words, to build parallel capacity for making vaccines in Panama, similar to what we're doing in Houston. Now you might say, well, why would I do it with Sabin instead of doing it with the Jenner Institute? And the answer is, you have to fly to England, whereas you can swim from here to Houston because we're so close. So we can't quite swim, but you get the idea. And so it's very easy to go back and forth. So that's what I'd like you to think about as I'm going through this presentation. Think about what I'm presenting here, what we're doing in Houston, could be also applied to building capacity for doing similar kinds of things in Panama, because I think Panama is on the verge of potentially doing something very big in biotechnology. So I'm going to start here talking about the Millennium Development Goals, we just finished the Millennium Development Goals. So the MDGs were launched in 2000. They ended at the end of last year. And they were created to give the world a platform for taking on the plight of people who had nothing, people who were living on less than $1 a day or $2 a day. And they've had a big impact because it's produced a lot of global action in response to them. These Millennium Development Goals were what launched the Global Fund to fight AIDS, TB, and malaria. They were used to launch PEPFAR, the President's Emergency Plan for AIDS Relief, to bring billions of dollars behind it. And one of the reasons they were so successful, because as we know, many United Nations documents are not so successful, was because it also did a lot of advocacy around it. And they brought in the celebrity community. So Bono came in and launched the One campaign. You had Brad Pitt doing a 4-part series on the Millennium Development Goals. And of course, if you get Brad, you got Angelina also, and so she got involved, in George Clooney, and this created a lot of momentum. And it turns out that we might have made some of the most progress on this particular Millennium Development Goal that I have underlined, number 6, which is to combat HIV, AIDS, malaria, and other diseases. And we made enormous progress on HIV, AIDS, not necessarily through vaccines, but through other interventions. And Professor Hill just walked in the room after I said all those nice things about you, Professor Hill, at Oxford University, and how we're fellow travelers trying to do the same kinds of things. But the difference being, I said they had to fly to see you, as they could swim and see me here in Houston. That's the only comparative advantage we have. All right, so we're part of this initiative at working with the Institute for Health Metrics and Evaluation to look at what some of the impact has been on these big picture interventions for HIV, AIDS, malaria, and other diseases. And the progress has been fairly impressive. And we know this because hundreds of investigators have worked together to actually analyze the impact of these big picture public health interventions. And I'm showing you this paper, not so you can look at it in detail, just to give you a sense of the size and scope of these projects. So this is half the author list over here. It looks like a paper produced from the CERN Physics Laboratory. I think my name's here somewhere. It's like, where's Waldo? You have to go looking. Here I am, over here in the middle, but you have to spend a fair amount of time. So it's this big initiative to really look at what the impact has been on all these big picture global health initiatives. And I'll give you the bottom line of work done by hundreds of investigators. And this is an initiative that's led by Chris Murray in Seattle. And what was found was that, and it's a very positive message, because it goes to show you that overseas development assistance makes a difference, because through the President's Emergency Plan for AIDS Relief and PEPFAR, more than 19 million lives have been saved from HIV/AIDS in terms of reductions in deaths. So we've turned the corner. Before PEPFAR and the Global Fund, the numbers were going up. As we put people on antiretroviral drugs, they started to go down. Also, a pretty big impact on malaria cases and deaths, a 30% reduction in cases and deaths. And not as dramatic an impact as you might see for vaccines for childhood infections, because through Millennium Development Goal number 4, we saw more than 80% reductions in measles deaths, Haemophilus influenza type B deaths, but making a lot of progress. There was one problem with all of this impressive advances was there was a third component that unfortunately got labeled other diseases. And other diseases was a really, really bad name, because you're not going to get anybody too excited about something called other diseases. And so what happened was a few of us got together, including 2 colleagues in the United Kingdom, David Molyneux in Liverpool School of Tropical Medicine, Alan Fennick at Imperial College London, got together and we kind of did a branding exercise where we call them the neglected tropical diseases, or NTDs, to reflect that these are highly prevalent among the poor. These diseases are endemic in rural areas of low-income countries. They tend to be chronic and debilitating infections, highly stigmatizing, and very importantly, they cause poverty. They both occur in the setting of poverty, and they cause poverty because of their long-term effects on maternal and child health, and also worker productivity. And we did a lot of work writing books on these diseases and other things along those same lines. And we now have come up with the new numbers on these neglected tropical diseases based on the Global Burden of Disease study. And the numbers are pretty impressive. They mean 800 million people with intestinal roundworm infection, 477 million with whipworm. A lot of these are worm diseases. Here's hookworm infection. Here's schistosomiasis, foodborne trematode infections, 58 million annual dengue cases, lymphatic filariasis, onchocerciasis, Chagas disease, still a big problem with 9 to 10 million people living with Chagas disease, leishmaniasis, trachoma, cysticercosis, echinococcosis, rabies, sleeping sickness, and then there's some that we did not have any numbers for. So back in 2013, we did not have numbers for yaws, Burley ulcer, Ebola, or Zika or chikungunya, but this kind of gives you the landscape of some of the most common afflictions of people who live in extreme poverty. We've now been doing a deeper dive looking at this part of the world, the Western Hemisphere, and the numbers show that the high prevalence diseases globally are not too different for the Western Hemisphere, particularly among the estimated 100 million people who live in the Americas on less than $2 a day. So you've heard of the term the bottom billion. Well, when we talk about the Latin American and Caribbean region, we're talking about the bottom 100 million. And pretty much all of the bottom 100 million are suffering from ascariasis, trichuriasis, dengue. Here's dengue, 54 million, hookworm, 30 million, Chagas disease, 7.8 million for this one. And now Zika's getting up there, so the World Health Organization is projecting 3 to 4 million people with Zika, just to kind of put this in perspective among other diseases. Schistosomiasis, 1.5 million, lymphatic filariasis, leishmaniasis, onchocerciasis, and then trachoma at the bottom. And of course, Central America, unfortunately, is punching above its weight in terms of its contribution to the neglected tropical disease burden. And here are our numbers that we recently published, which is that out of a population of 44 million people in Central America, there's 10 million who live in extreme poverty, 17 million at risk for malaria, and that's why I asked about the malaria question to GSK, whether they would consider introducing it for the Americas. I'm aware that there's a lot of Vivax, but there's also falciparum as well. 8.4 million children require deworming, 4.7 million people with dengue fever, 806,000 people living with Chagas disease in Central America, 30,000 with new cases of cutaneous leishmaniasis, and of course now we've recently learned that Zika is emerging. It's hitting the areas of Panama adjacent to Colombia, and I think if it goes by the same playbook we've seen in the rest of Latin America, we can expect it all over Nicaragua and Central America in the coming weeks, so very soon. So this is going to be a huge threat to the region. And the impact is very important, not only in terms of deaths and some of the more dramatic things that we hear about, but of course also long-term debilitating effects. And one of the things we've recently done has come up with this interesting worm index, which actually uses WHO data on neglected diseases to calculate a number that looks at the impact of neglected tropical diseases on a given country. So the United Kingdom's worm index is 0, but then you get into the Indias and Indonesias, and as you move towards the Nigerias of the world, these are the largest countries. As that goes up, your Human Development Index, which is a complex measure that looks at life expectancy, quality of life, educational attainment, how you treat girls and women in your country, that goes down. So they tend to cross. As Human Development Index goes down, worm index goes up, and we're trying to actually try to get some better sense of cause and effect in that. Now, the problem has been, what do we do about interventions? And this morning, Professor Hill, Adrian, beautifully spelled out the problem with Ebola. And I'm going to basically say it in even starker terms. This was the paper of the adenovirus vaccine that was published back in 2003 by Gary Nabel's group, together with others at the Vaccine Research Center, the NIH. The point being, the technology to make the vaccine was published in 2003, and then it sat there for a decade with incremental progress, little things happening. But basically, the technology sat there, and it was only when things became so dire back in 2014 that people got very worried that Ebola could become a pandemic that could go beyond Guinea, Liberia, and Sierra Leone, and the world recognized that we need a vaccine. And what happened was the US government, through BARDA, the Biomedical Advanced Research Development Agency, put up $100 million. GlaxoSmithKline, Merck, Crucell, all made Ebola vaccines, and they did it with incredible speed. I was really amazed how impressive their achievement was. But of course, by the time the vaccine was widely tested, Ebola was gone and 11,000 people had perished because we have a situation where our technical ability to make vaccines has outpaced our political, social, and financial instruments that we have to make those vaccines produced and then available. So the message that I'm trying to get across, and it's been one that's been very difficult for people to hear in Washington, is the old-fashioned way of making vaccines, which is an academic researcher makes a promising discovery and then license it to a big pharmaceutical company. That works for some things, and you cannot argue with success. That's been very successful. But for some of these other vaccines for other diseases, we're going to need new roles, new actors. And for that, that's where the Jenner Institutes of the world come in and the Sabin Vaccine Institutes come in. Sometimes they're known as product development partnerships, which are nonprofits that use industry practices to make the products that the big pharmaceutical companies won't make. And here are some of the logos of the vaccine product development partnerships. The idea is they're going to try to take these on, and they'll partner with industry, but largely shepherd them through in the non-profit sector. And ours is based in Houston, Texas, at the Texas Medical Center, and this is the building that we're in. It's a massive research building, and we're on several floors of this building. We're advancing a portfolio of vaccines that more or less GlaxoSmithKline or the others would probably struggle to figure out a way of what the business model is where they could take these on. So let's look at a few of them. We're making a vaccine for a hookworm infection, and hookworms are small animals about 1 centimeter in length that have the ability to feed on human blood, and they're a major cause of anemia in Central America and South America, certainly Africa and Southeast Asia. And the problem has been the more worms you have, the greater your loss in intelligence. So worms are not killing these kids, but they're shaving IQ points off. And we're also finding huge numbers of complications in pregnancy. So up to 1/3 of pregnancies in Africa are complicated by hookworm. And the reason that's important was really spelled out to me when I talked to the head of our obstetrics and gynecology department at Baylor College of Medicine, who said, you know, Peter, a woman, when she dies in childbirth from bleeding in sub-Saharan Africa, it's not because she bleeds more, it's because she has a hemoglobin concentration of 6 by the time she gets to the labor and delivery suite, and it's because she's co-infected with hookworm and malaria. And this is a study we did with Simon Brooker a couple of years back in the London School of Hygiene and Tropical Medicine. Wherever we have the green there are co-infections with hookworm and malaria. So I was hoping to see Dr. Slawi here, where GlaxoSmithKline is making a malaria vaccine. What we should be doing is combining it with our hookworm vaccine to target anemia, especially during pregnancy, and maybe we'll continue to have those discussions. And then, of course, there's the big impact on poverty. Hookworm leads to a 40% reduction in future wage earnings because of the impact on child development. So we've been working to dissect out the mechanisms by which worms feed on blood and then interfere with it, and it involves these membrane-associated enzymes that attach to the inside of the gut by putative GPI anchor sequences, and we're able to stimulate a host immune response against them, and the worm ingests the antibody and can't feed on blood. So this is a worm removed from a vaccinated animal, and the antibodies have bound to the worm and then interfered with its ability to feed on blood, and it makes a very good vaccine in the laboratory. We have a second antigen, which is a glutathione S transferase that's unique among hookworms, that it binds heme, and heme is very destructive to blood-feeding parasites like malaria that polymerizes it into hemozoin. In the case of hookworms, they detoxify it by binding it to this unique GST. And so we've now manufactured these antigens and have been testing them for a number of years in rural Brazil. And with what we've now been able to show is we get a pretty good immune response with the recombinant protein on alum, but we need help. We need another adjuvant. And this is one of the problems that we face, not being a major pharmaceutical company, but being a small product development partnership. We have limited access through licensure to other adjuvants. So we have some good access to a synthetic lipid A from another product development partnership known as IDRI, called glucoparanylyl lipid A. We have access to another TLR4 agonist from a Japanese company, Eisai, called E6020, CPGs, but it's a limited armamentarium. But we're making good progress and are having good antibody responses. And now, through a European Union grant, we've created a consortium with several European institutions and are testing this in the Albert Schweitzer Hospital now, where we're doing step-down studies, and hopefully we can move pretty quickly now through advanced clinical development. One of the problems that we face, again, being a small product development partnership, is getting to the end game where you have to do larger phase 3 clinical trials, and also you have to remanufacture your product because the same processes that you would use to make a phase 1, you have to redesign them in order to make phase 3 industrial scale material, and that of course requires a higher level of resources. We're also finding that wherever we find hookworm, we're finding schistosomiasis, and now we have a vaccine for that targets the outer membrane proteins of schistosomes that also make very good vaccines in the lab. This one has now been manufactured, and we just completed phase 1 clinical testing, and this was done in Houston through an NIH-supported vaccine grant. So we're advancing these pretty quickly. As that's going on, we're starting to think of how the landscape is going to change since the Millennium Development Goals, and now that we're moving into a new set of what we call sustainable development goals, and giving a fair bit of thought to what the future landscape is going to look like in terms of neglected tropical diseases as we advance our vaccines. And this is new data that we've recently published that's in terms of the demographics on where neglected tropical diseases are. And we used Institute for Health Metrics data from the Global Burden of Disease study combined with WHO, and the two are remarkably concurrent. But here's one of the really striking findings that we've made, at least I think it's striking, and that is when you think about global health problems, we think about developed versus developing countries, not really paying attention to the fact that within the so-called developed countries, the G20 economies, the world's largest economies that are known as the G20, what we're finding is very high rates of neglected tropical diseases among the poor who live in those countries. So if you look at the 20 largest economies, they now account for 50% of the world's helminth infections, most of the dengue, Chagas disease, leprosy, tuberculosis, and about half the malaria and HIV/AIDS. So it's the poor living among the wealthy that account for most of these diseases. A good example is Panama. Panama is a wealthy country, but it's not a wealthy country. We have great pockets of poverty amidst wealth. It's the poor that are suffering from those diseases. So if we let's look at Brazil, for instance. This is a poverty and disease map of Brazil. And if we go into Rio de Janeiro, Sao Paulo, we can see great wealth. If you go up into Recife and Pernambuco State, enormous poverty where you have lymphatic filariasis, schistosomiasis, and that accounts for most of the schistosomiasis, lymphatic filariasis in the Americas, and of course that's where the Zika is. So Zika struck Pernambuco, not by coincidence, it was because of the extreme poverty there. The same is true in Western China, where China, enormous wealth in Shanghai or Beijing, but if you go into southwestern China, to Guizhou, Yunnan provinces, you go back in time 60 years and see great poverty. What's going on here? Does the U.S. have poor people? So how many poor people are in the U.S.? A lot. Okay, that's true. We have 20 million Americans who live at 1/2 the U.S. poverty level in extreme poverty, and we have 1.65 million families that live on less than $2 a day, and most of them are concentrated in our southern states. And Texas, it turns out, has the largest number of Americans who live in poverty, and that's why the School of Tropical Medicine is there. We call them neglected tropical diseases, but they're diseases of poverty. So what I'm showing you here is a risk map of Chagas disease in Texas. We now Donald Trump would say it's because we didn't build the wall high enough, but in fact we have transmission of Chagas disease in Texas. 10% of the dogs in Texas are infected with Trypanosoma cruzi. Okay, the dogs are not slipping through the wall. We have transmission there. We have non-human primate colonies in Texas, such as in San Antonio or at Bastrop for MD Anderson. 7% of the rhesus macaques living outside are infected with Trypanosoma cruzi. So we have lots of transmission going on, and we're just really trying to get our arms around it. And now we've been making vaccines for Africa and the world's poorest people through hookworm and schistosomiasis, but now we're actually making the case that Texas is a disease endemic country, and we're making vaccines for the poor who live in Texas as well. So the Chagas disease is an interesting one. We have no active surveillance in the state, actually no active surveillance anywhere in the country, so we don't know the true number of people infected. We know there's a lot of infection going on. We have been able to identify individuals who get picked up through blood screening. So they go to donate blood. We now test for Chagas. They're told they have Chagas, and what's been happening, they go see their primary care physician who says, oh, we don't have that disease here, don't worry about it, it's a false positive. We've now been able to track them down, bring them to our tropical disease clinic, which is quite unique because it's not a traveler's clinic, but it's a tropical disease clinic for people who contract their diseases in Texas, and able to track them. A number of them have severe heart disease. Christy Murray on our faculty found that Houston regularly experiences dengue epidemics. It's just that nobody was looking. People were coming in with fever and a rash, and nobody realized that it was dengue. So altogether, we now estimate there's 12 million Americans living with a neglected tropical disease. And that's very important because when we talk about things like Zika and dengue and chikungunya, because the U.S. government now, through the CDC and the U.S. Public Health Service, is saying more or less, yes, Zika is marching through Central America and the Caribbean, but it won't come to the U.S. because everybody has air conditioning, everybody has a higher standard of living. I'm simplifying, of course, but we're pushing back a lot because what we have in Texas is, especially along the Gulf Coast, where the poverty in the U.S. is the greatest, we have both Aedes aegypti mosquitoes and Aedes albopictus mosquitoes, and we know Aedes aegypti is a very efficient vector of Zika. And so not only do we have the vector, but guess what? Not everybody lives in wealth and air conditioning. So this took me 5 minutes. This is 15-minute, not a 7-minute drive from Texas Medical Center, the world's largest, most sophisticated medical center. And here's what you see. And you go through the historic wards of Houston, mostly African American and Hispanic, and it's mostly linked to poverty. So these are people living here with no window screens, or if they have window screens, they have holes in them, no air conditioning. And what do you see along the sides of the road? Discarded tires. I took this after we hadn't had rain for a while, but if I had taken this after a rainstorm, all of these tires would be filled with water and all sorts of organic debris. What does this look like? This looks like the movie you show to the first-year medical students when you're teaching them about global health, but it's here in Houston. So we're doing a lot of work now talking to Congress about the fact that we do think the Gulf Coast area is extremely vulnerable to Zika, as it is to the other neglected tropical diseases like Chagas disease and others. And it's a message that Americans don't like to talk about. We don't like to admit that we have this level of poverty and disease, but it's basically a continuum all along the Western Hemisphere. So Christy Murray and Melissa Nolan Garcia, and together working with Lila Waugh Colburn, who many of you will recognize, who's from Panama, have been working to, for instance, not really understand the extent of transmission of Chagas disease and conducting that kind of active surveillance that needs to be done. And then we got drawn into making a Chagas disease vaccine. The problem with Chagas disease is the two major drugs that we have to treat it, benznidazole and nifurtimox, work very well during the acute stages of the disease, but almost nobody is diagnosed during the acute stages of the disease. The vast majority are not diagnosed, and they go on to become what's known as, they're seropositive. They go through what's known as the indeterminate stage, and then about a third will go on to develop Chagas heart disease and cardiomyopathy. And the effectiveness of the drugs diminishes as the disease progresses, so that they may not be effective at preventing heart disease. So the idea behind our Chagas vaccine is not, at least the way we've initially designed the target product profile, it's not a preventative vaccine. It's a therapeutic vaccine to give alongside the medicine to improve the efficacy to prevent the onset of Chagas cardiomyopathy. And this has been a really interesting project for us because one of the great things about the Texas Medical Center, it was built around the legacy of Michael DeBakey, who was one of the founders of heart surgery in Denton Cooley. So the strength of the Texas Medical Center is this very rich background of cardiology and cardiothoracic surgery research. And basically, if you throw a stone anywhere in the Texas Medical Center, you'll hit a cardiologist or a cardiothoracic surgeon, and we're taking advantage of all this. And they've built incredible imaging facilities for non-human primates and mice, which we can now take advantage of by giving these mice Chagas disease and looking at some of the effects. So we've been able to Jonathan Respris now, who's a cardiac physiologist who works with us, has now been able to reproduce a lot of the ectopic activity. So much of the time you die of Chagas disease, the cardiomyopathy is not necessarily always that big dilated heart that you see in the textbooks, but it's often more subtle changes to the conductive system. So we've been able to reproduce this pretty nicely. And I don't know if the videos will work, but so this is, I know you're not mouse cardiologists, but this is what a normal beating mouse heart looks like in our imaging facility. And now we can reproduce this. This is a mouse infected with Trypanosoma cruzi, and you don't have to be a cardiologist to say there's something really wrong here. It just stops beating for periods of time. It's big and dilated. And so what we're now trying to do is see if, with our vaccines, whether we can prevent some of these things from happening. So we've called this concept of the poor living among the wealthy a different name. We call it blue marble health. That it basically says that the most of the neglected diseases are among the poor who live amidst wealth. And that has a lot of important policy implications, because it's saying if these are the 20 largest economies, it's not the usual type of overseas development assistance where wealthy countries give things to poor countries. What it means is we need to convince the leaders of the middle-income countries and the G20 countries that they need to do more for their own neglected populations, both in terms of making medicines accessible as well as research and development. So for instance, in the United States, among those 12 million Americans living with the neglected tropical diseases, we have hundreds of thousands now living with Chagas disease, and less than 1% have access to diagnosis or essential medicine. So they're almost completely not followed at all. And this is true, of course, in Brazil and elsewhere. The other piece to our reanalysis of neglected diseases beyond poverty is also conflict or post-conflict. And this seems to be an equally important driving force for the world's neglected diseases. And we can overlay this nice map of conflict and disease. And again, to go back to the story of Ebola, why did Ebola rise out of West Africa, out of Guinea, Liberia, and Sierra Leone? It's not because it was tropical, maybe that was a part of it, but instead those three countries had gone through horrific atrocities for a decade or more, and as a result, their health system completely collapsed. So conflict and post-conflict has these well-known effects on destroying healthcare infrastructure and helping to promote the emergence of neglected diseases. And we're now seeing those same forces in play in the ISIS-occupied countries of Syria, Iraq, and Libya, as well as Yemen. What we've seen over the last few years is the reemergence of measles and polio, massive uptick in the number of cases of leishmaniasis, hundreds of thousands of cases of leishmaniasis, resurgence of schistosomiasis. Not only people are being trafficked with the conflict, but animals are being trafficked. So all of the veterinary public health that was in place at one time has now evaporated, which is contributing to widespread brucellosis. MERS coronavirus infection. We've seen a big uptick in dengue fever, malaria, tuberculosis. So this is going to be one of the next big hot zones of the world. And so what do we do about it? Well, President Obama back in 2009 made this historic speech in Cairo where he talked about reaching out to the Muslim world and the arts and the sciences and created this Science Envoy program. And what we've been doing is working with some of the more technologically sophisticated OIC countries, Organization of Islamic Conference countries like Morocco and Tunisia and Saudi Arabia, to see if we can build vaccine development capacity there. Because right now there's almost no vaccines made in the Middle East and North Africa region, and despite the fact that there's a fair bit of wealth. And we've recently signed this agreement with King Saud University in Saudi Arabia to see if we can build something that resembles Sabin Vaccine Institute there. And we're doing this in Malaysia. And this, again, just to come back to why I'm in Panama, why I come to Panama so frequently, we think Panama is a great place to potentially do that in Latin America and the Caribbean region. So these are some of the diseases that we're seeing, this huge increase in leishmaniasis, especially cutaneous leishmaniasis, where because of and the locals in Syria call it Aleppo evil, it's not a killer disease, but it's disfiguring little girls and rendering them unmarriageable. And the treatment requires intralesional injection of meglumine or sodium stibogluconate, which of course is not available. When you have all the collapse of any kind of infrastructure, the garbage collects, the sandflies are proliferating, and then the sandflies are following the refugees who are fleeing the conflict into Jordan, into Egypt, into Turkey, into Lebanon, and elsewhere. So this is a major problem. We're now working on a leishmaniasis vaccine with Jesus Valenzuela's group at the National Institute of Allergy and Infectious Diseases, who's found that the sandfly proteins are as important as the parasite proteins in terms of stimulating protective immunity. And we're also now looking at some of the coronavirus antigens, and we're focusing primarily on the receptor binding domain of SARS and MERS coronavirus, where we're getting great levels of neutralizing antibodies. One of the problems that we're finding if we use whole subunit vaccines or whole killed vaccines is we get a lot of immune enhancement, eosinophilic immune enhancement, which actually makes things worse, and this was found with RSV. So I've gone on longer than I should. I'll end here just by saying I think how we make the vaccines may be as important as what we make. Not many people know the story, but when Albert Sabin developed the oral polio vaccine, he didn't do it by himself. It was done as a joint US-Soviet collaboration at the height of the Cold War, where Dr. Chumakov got back channel permission to visit Dr. Sabin. Sabin sent his vaccine strains to the USSR, and just 2 years after the Sputnik launch, this vaccine was tested in more than 10 million Soviet school children, and this is what led to licensure of the oral polio vaccines most of us took as children. The point being that we think it's very easy to get, not easy, but doable to get two countries to put aside their ideologies to work together for making vaccines. We're doing this now in the Middle East and North Africa, and I think if we could do it there, we could certainly do it in Panama, where we're friends, we use the same currency. This should be the easy one, and so let's see how we can make that happen. So thank you very much for listening. Time for a couple of questions.
Yeah, we have time for some questions.
Thanks a lot, Dr. Hotez. A very nice presentation. I would like to have your opinion on the current dengue vaccine, because this vaccine is kind of a booster vaccine because it doesn't work very well in seronegative, pretty well in seropositive. The coverage of serotype 2 is lousy. And we have chikungunya, we have Zika. So that introduction of the vaccine can give us a false sense of security. And then abandon the control of the vector. And that could be very dangerous if we do that. So are you positive about the introduction of this vaccine in endemic countries right now, or is better to wait, for example, research in other vaccines that are in phase 2, phase 3 trials right now?
So we could do a whole hour discussion about it, but let me pick out a couple of pieces that I think are interesting. I like to say that we already did the easy vaccines, right? We did the polios, the measles, that give 95% protection, amazing protection. And this next generation of vaccines coming online, including our vaccines, the dengue vaccines, just are not going to be as effective. So what this means is we have to change our way we think about introduction of these vaccines. We're still fixed on saying that the vaccine is going to replace everything we did before it. And this is going to be some kind of magical panacea, and it's not. It means that these vaccines are going to could improve existing public health control measures, but they cannot replace it. The RTS malaria vaccine from GSK cannot replace anti-malarial drugs and bed nets. We're going to have to keep that going. The HIV/AIDS vaccines that are coming online will probably not replace antiretrovirals. Our hookworm and Chagas vaccines and Shista vaccines will not replace mass drug administration. A dengue vaccine is not going to replace controlling the Aedes aegypti mosquito. And that's a very hard message to make. So the level of advocacy that you're going to have to do to make people aware of that is very high, because we're so fixed on how we think about vaccines. I think that's the first point. I think the second point with regards to the introduction of the Sanofi vaccine, first of all, I think it's courageous that these companies are still interested in trying to make vaccines, and they deserve credit for it. One of the issues that will happen as it becomes registered in a place like Mexico, where you have lots of dengue transmission going on, is you always worry about the immune enhancement phenomenon, where if you get one dengue serotype, then you get a second, and then that's where you get into trouble with dengue shock syndrome and hemorrhagic fever. So the only thing I could say is if you're going to introduce it in a highly endemic area, including places like Panama, your post-licensure surveillance is going to have to be very robust to look for this, and because we're dealing with unknowns. And so that's I guess the point I would make about that. I think there's actually going to be some information coming out in PLOS NTDs about this in a few weeks also. So stay tuned for. I don't want to give the punchline away, but stay tuned for that.
Hello? Can you hear me? Hello? Hola? Okay. So I have a question in regards to your words of vaccine diplomacy. As you were saying, you want to implement the same institute or the same research institute here in Panama? No,
But
inroads.
something that would allow you to build some vaccine R&D capacity, but do it working within the culture of the existing institutions here, like INDICASAT and Gorgas, etc.
Okay, so the question I want to ask is, what is the progress currently in creating such an institute here in Panama, or like the inroads you're doing currently to open this kind of research, this R&D development here?
So it's moving. It's moving slower than I'd like, but it is moving. It's having a lot of discussions. One of the whereas the other countries we've been working in, Saudi Arabia, and Malaysia, and Mexico, these are huge countries by comparison to Panama. Panama has limitations because of its size. It's a country that has a population smaller than Houston, right? So I think we have to be realistic about keeping that in mind. Having said that, I do think Panama has enormous potential. And if you think about where biotechnology is starting to take off, Brazil has always been sort of at the top. They're having a lot of difficulties now with their economic downturns. Colombia has done well. Maybe this could be done jointly between Colombia and Panama. I don't know. But I think Panama is certainly a country that we have to look towards because it's a stable country. It's got a relatively strong economy, and it has some sophistication in science. So, those are the things that we looked for in the Middle East and North Africa. You wanted all those things in place, and I think it's in place here. What do you think? Not really sure. Yeah, I mean, I think we have to try, and as I said, the geographic proximity is great. I mean, I can get from Houston, I can get to Panama faster than I can get to many parts of the West Coast or the Northeast, and so that's also very attractive.
Thank you for your presentation. I quite enjoyed listening to you, and you gave us a panoramic view of these neglected tropical diseases across the world with more emphasis on the Western Hemisphere, understandably so. A couple of quick questions and comments, seeing that we still have a lot of time left and there's only one panelist. First, as we understand, I come from India, that these tropical diseases have persisted over the years, millennia, because these diseases belong to tropical countries which are necessarily poor, and most of these countries are in the south versus the north, as the traditional debate has gone on. And it's of late, relatively late, that a lot of these big multinational corporations, in fact, this session is also, if I see, is in collaboration with one of these companies, that they have started investing in these diseases. After all, one understands that profitability remains an important criterion along with other factors. Now, as you gave us a worldview, would you quickly tell us a little bit about what kind of international cooperation across the frontiers is taking place? Because most of the tropical diseases, I come from India, though India has a huge biotech industry and it has made, I would say, huge strides as well, but still we have a lot of challenges there given the sheer size of the population in the country and China as well. Being in Panama, I've been here for about 1.5 years, and so many times I thought that there should be a more active cooperative program, let's say even these communicable diseases or in these tropical diseases in India, or between India and Panama, India and some, Panama and some other countries. Of course, one understands the cooperation going on between the US and Panama, but why not other major tropical countries? One. And secondly, I just want to ask you something. In one of the slides, it was on conflict and contagion and conflict. You showed India affected by conflict or contagion. I really didn't understand that context. Thank you.
Okay, where to begin? Let's see. Well, first of all, I think India is part of the solution. India has some of the most robust vaccine manufacturing capability anywhere in the world. It tends to be mostly in private companies, but they so far have started to show a very exciting track record. So, for instance, most of the measles vaccine for Africa is made by the Serum Institute of India in Pune. Serum Institute of India in Pune successfully manufactured a new vaccine for meningococcal A. And so we're looking at that very seriously as a partner. So we recently got funding through the European Union to do a landscaping exercise of Indian vaccine manufacturers. And so we'll be talking to a number of them, including Zydus Gedelia and BioE, Bharat, and numbers, and see if they would be good partners for us. In terms of the international cooperation, I think you're absolutely right, particularly among the G20 countries. And this is sort of the next big hurdle I think I want to take on, is if it's true that most of the world's neglected diseases are in the G20 countries, and if it's true that if the G20 countries would take on their own vulnerable populations and neglected diseases, and that includes India and includes the US, we could wipe out 2/3 of the world's neglected diseases. So how do you shape the policy around that? And I think a great opportunity would be to do that at a G20 summit. The G20 countries meet every year. They are going to be, they've recently met in Russia. We need a G20, at a G20 summit, I think we've got to figure out a way to put neglected diseases on the agenda. Short of the G20, I think using that cooperation from one country to the other is also doing bilateral engagements. Of course, India should be working with Panama more. I think that would be a fantastic cooperation. I think countries have underutilized science and biotechnology as a diplomatic tool. I think in the little bit I've done in Saudi Arabia and Morocco and Tunisia, I've seen how powerful it can be and how badly people want that capability. I think it's another side of the U.S. that I've been really impressed with. No matter where I've gone in the world and talked to a leader of a country, that individual invariably has studied at the University of Illinois, or has studied at Texas A&M, or has studied at Iowa State University. And so our big land-grant universities have basically trained a whole generation of global leaders. And I think we often forget how powerful that is. So when Donald Trump goes and says those inflammatory things about Muslims, I'd be worried, well, how am I going to be received when I go to Saudi Arabia? Actually, they say, we know he's full of crap. I spent 5 years living with a family in Ames, Iowa, while I was at Iowa State University getting my bachelor's degree and master's degree. And so this has been very important in terms of how we project ourselves as a nation, and we shouldn't underestimate that. And the same with your universities and research institute. Your Gorgas Institute and INDICASAT are the best diplomatic tools you have as a country, and something that you need to be proud of and highlight. And not just us, but your University of Technology and others. But we haven't really figured out a way to incorporate that fully into how we send our diplomatic messages and how we teach our foreign service officers how to act. So that's going to be a great challenge as well. Your last question was about conflict. Why was India lit up as a conflict area? I think it had to do with some issues they've had with probably more historical regarding nuclear capabilities and nuclear threats between China and India. Pakistan, probably what was the basis for it, but I'd have to look back at that map. That map came from another publication. I'll have to go take a look. What's that? I'd have to look back and see how it was listed, but we'll take another look. In version 3.0, we'll take it off the list of conflict countries. But there's still a lot of disease.